And it is my pleasure to announce our last presenter. Coming to the stage is Dr. Zach Walsh. He is on the advisory board of EntheoTech and has been involved in several well-published clinical trials. He's going to be talking about the systematic review of literature as it is related to ketamine. Thank you very much.
Hi, everybody. Thanks so much for waiting around and for your attention. It's great to be talking about ketamine. I think it's such an exciting new intervention. It's so needed, particularly as we're looking just this past week at the devastating statistics around the opioid overdose crisis. And we know that mental health and depression and PTSD underlies so much of that suffering. So this is really, I think, one of the major challenges, if not the major health challenge of our generation. So I'm excited to be able to talk about what I see as some potentially exciting solutions. And also, I'm always a skeptic. So I'm excited and skeptical at the same time. So I'll go over that. Keeping that in mind, I want to talk primarily about a review that I think it just came out a couple months ago by myself and a really great international team of researchers, where we did a systematic review of ketamine and mental health. So we looked at just about everything that's been published on the topic up to 2020. So there's a couple new things, but this should pretty much give you a good sense of where the literature's at, what we know, what we don't know, what are the limitations. And there are a lot of limitations, but I think the news is generally good. So so I always want to start with a disclosure, first of all, acknowledging that we are on the unceded territory of the Syilx Okanagan people who've lived here since time immemorial. And of course that, the psychedelic work that we're talking about has deep roots in the indigenous peoples of Turtle Island. And so as we transition that technology and try to borrow from it, I hope that we can do it in a way that's respectful and that acknowledges those roots, because that is the technology that we're borrowing from. And it's a long-standing one. So I always want to talk a little bit about myself. I'm a professor at University of British Columbia, Department of Psychology. I've been working in psychedelics for over a decade, psychedelics and cannabis. I have a number of disclosures to make. First of all, I've been a paid clinical worker for MAPS, the Multidisciplinary Association for Psychedelic Studies. And I've also done paid work for Numinous, which is a group in Vancouver that's doing psychedelic psychotherapies as well, helping them to develop ketamine treatments. Who else do I work with? I work with EntheoTech as well, Mycomedica Life Sciences, which is Paul Stamets and the psilocybin group there, and MAPS Canada as well. My research, but that's not it. I don't only take private money. I've also been funded by CHR and SHRC and MyTax and the Institute for Healthy Living and others at UBC. So that's me. So before I get into the systematic review, I always like to give respect out to the pioneers in the field. And one person that I think it's important that we not overlook is Phil Wolfson, the developer of CAP as we know it. And I feel really lucky to have been trained in CAP by Phil Wolfson. And he was an early proponent coming out of the psychedelic psychotherapy movement, who really encouraged us to examine ketamine and look at that potential of ketamine as a psychedelic. So, as little as 10 years ago, and I'll show you a graph in just a moment that looks at the interest, but this is really new stuff. And so he's one of the people that is an important transition. A few other names that I don't know if they've been mentioned. I was coaching soccer for 6-year-old girls before I got here, so I'm sorry I missed the early presentations. Got to mention John Lilly, though, the inventor of the sensory deprivation tank, and also an early proponent of ketamine as a psychedelic, and really a weird guy. He did stuff with dolphins that we don't talk about, but still worth mentioning. And speaking of weird guys, Salvador Roque, a pioneering psychotherapist from Mexico, who was actually probably the first person to use ketamine in a psychedelic psychotherapy context, but also did some questionable stuff with the CIA. So, but there are a lot of good people too. So there's a couple points coming out of Phil Wolfson's work with CAP that I think are worth talking about, and they really I think they dovetail nicely with the great talk that we just heard about the Odyssey program, and that's that it's a deeply psychotherapeutic process. And a lot of the research that I'm going to show you today, I don't think acknowledges that. So it's really a lot of it is from the infusion model, and it's looking entirely at sort of the psychopharmacological effects without looking at that integration that I think is really key, and that Phil Wolfson thinks is key as well. And if you're interested in learning more about his process, that article that I have cited up there, that's pretty recent, and I believe it's open access, so you can look it up, and it talks in great detail about his method, and it provides some really nice examples of successful outcomes across a range of disorders, but it's not RCT. They also avoid the IV medical model, so you've probably heard a little bit about that, and some of the downsides of that, even though much of the research that we're going to talk about comes from that. And importantly, therapy is an integral part of the process. So as I go through this literature and we look at some of the relatively brief transient effects, as impressive as they are, I really want to keep open in your mind the possibility that these effects could be dramatically improved with a combination of proper therapeutic interventions. And because the review stops at 2020, I also wanted to share with you some other open access articles that I think are really exciting that talk about this idea that we need to find ways to integrate psychotherapy in meaningful ways with the ketamine experience. And the top one by Alberto Garcia Romeu from Johns Hopkins. He's a great psychedelic researcher, and so anything that you see by him is pretty reliable. And he talks about combining ketamine with third-wave behavior therapies like ACT, which I think is really positive. This is an exciting theoretical piece from out of Alberta, looking at culturally attuned trauma-informed psychotherapy. And a group that you should really know about is the group that out of Victoria, out of VIU, that I've been fortunate to work with them as well. Shannon Dames, in particular, leading the Roots to Thrive program, which uses ketamine for PTSD in healthcare providers. So this is providers who are burnt out and have trauma, secondary and some primary trauma, as part of their work in healthcare. And they've had tremendous results. So I'm not going to talk about these results today because they're a little bit newer, but I do encourage you to look into those. And with all the positive stuff, I also want to point out that we can expect some backlash, and we always have to remain skeptical, because for those of you, many of you have worked in healthcare broadly and mental health, and we know that there have been many revolutions that have come and gone, and we wonder what happened to them. So keeping that in mind and keeping a critical eye. And this from Scientific American, I thought, picked out some of the concerns, right? That it can be quite expensive and profitable, and if you're not combining it with psychotherapy, there's some concerns that people are spending money for something that's not going to have long-term positive effects. And that's the second point that Scientific American article makes, is that some clinics aren't offering adjunctive psychotherapy. They're just doing the infusions. That's in fact been the model over the last couple of years. So I'm really excited about the Odyssey model and about EntheoTech really putting forward, or EntheoMed putting forward, the importance of combining it with psychotherapy. So without further ado, I'll get into the results of our review conducted by me and some my grad students, and also some students from the UK, and David Nutt from Imperial College, and Celia Morgan from Exeter. So some people with some pretty deep experience in ketamine. Dr. Morgan was really a pioneer in some of the Spravato trials and is working with ketamine pretty much longer than anyone I know from an academic perspective. And when you see this graph, this is the research. And you can see it's very flat looking at ketamine and mental health until 2012. And I think that graph speaks for itself. Right, you can see that rapid increase. So even now, if we were to look at stuff from 2021, I showed you a couple articles, but there's a few new ones as well. So I encourage you to keep your eyes open for new research. But what I can tell you is that we're going to look at everything up to 2020. And what is everything that fit our criteria? With 83 reports, 33 reviews, with 17 of them meta-analysis, 29 randomized controlled trials, some retrospective reviews. I feel like this is the Christmas song. 6 open label trials. Is that called the Christmas song? And so, but it's a mixed bag, but it's pretty good, right? There's a lot there. And when you look at the systematic reviews, there's so much on ketamine and depression that we didn't look at everything. We just did a review of reviews because there are so many reviews there. So the research is really deep on ketamine and depression, ketamine and suicidal ideation. It is reliable and it's rich and it's robust. And it's pretty consistent. So with depression, the 24 systematic reviews, 12 meta-analysis, that's a lot. Like, I don't know if we need to do more at that point. That is quite a substantial number. And especially when they're so unequivocal. We pretty much see the same thing every time, which is that rapid, robust, and unfortunately short-lived antidepressant effect. Part of that short-lived effect, though, is also an incredibly rapid onset, which is kind of miraculous, right? And we know the suffering of severe depression, treatment-resistant depression, and suicidal ideation. So that's nothing to scoff at, even if it doesn't last as long as we might like. To be able to relieve that agony almost immediately is tremendous. And typically it did persist for 1 or 2 weeks. And 2 weeks without depression for folks who have been struggling for a long time, that's a pretty nice window. And a lot can happen in a couple weeks if you've been struggling with depression for years and years. So I don't want to dismiss that. We say it's rapid and that it's short-lived, but I think that's nothing to scoff at. Also, the review shows that if you do more, it lasts longer. More pronounced effects, stronger effects, and more long-lived effects. And we'll see that consistently across the different disorders. Also, it's effective with treatment-resistant depression and also non-resistant depression. And another nice thing about it compared to some of the other psychedelics, which require a tapering off of other medications, you can use ketamine concurrently with other antidepressant medications. It seems to be just as effective in people who are using or people who have washed out. Adjacent to all this work on depression is bipolar disorder, and a lot of these reviews are the same reviews as depression, so they mix the two together, and the effects are very similar. But again, this is a robust literature, 9 meta-analyses, and only a few of them were only for bipolar, but they found almost the same effects, which is that you have really consistent and dramatic effects with very rapid onset and a duration, it's 4 hours to 24 hours, the onset. And so it seems like the effects are a little bit briefer even in bipolar, and that could be because it may be a more severe disease. It may be a more severe manifestation of a similar disorder. So it may be that it's bipolar specifically, or it could be that people are less well who present with bipolar. But either way, we see these same effects, a rapid decrease in depressive symptoms, and that diminishes after about a week or 2. Suicidal ideation, this is a distinct set of analyses, and this is really, I think, one of the most promising things for ketamine. It's almost miraculous when we see this turnaround with suicidal ideation. And we can't downplay that at all, because suicide is a major cause of mortality in our society, especially for young people. So when you think about suicide in terms of life years lost, it's tremendous. And we see a variety of doses. One thing that I hope you'll take away from this review too is, as you try to make sense of all this literature, is it's so diverse. So in these reviews, the doses range from 0.1 to 3 milligrams a kilogram. So from a minuscule dose to what I would say is a very, very heavy dose. And when we look at the literature, we see about 1 milligram per kilogram seems to be, I'd say between half and 1 milligram seems to be the most effective. In a few of these reviews, only looked at a single dose, and the ones that looked at more than one didn't directly compare. So when I say the literature is robust, it's consistent for single dose, but we still don't know exactly what happens when we extend the dose. There's a number of single trials, but they haven't been sufficient to combine and meta-analyze. And I think another important point about this is that we see across the board moderate to large decreases, and that they again appear almost right away and are maintained for a week. So I'm sort of repeating the same thing over and over again, but I think that's worth noting, is that across these disorders, across these conditions, we see similar effects. And as a researcher, it makes me wonder, are we treating some sort of underlying transdiagnostic feature? And I think probably that's what it is. For those of us who are sort of involved in some of the nitty-gritty of psychodiagnosis, that seems to be where things are going, that we're increasingly recognizing that these DSM categories are highly artificial. They might be useful sometimes for chat between providers, but do they really break nature at the joints? I don't think so. So it could be the ketamine and psychedelic therapy more broadly is getting at this deep underlying distress that runs across diagnostic categories. So a little bit different now. So that's really where the meat of the research is, and all the meta-analyses and the things we can be really confident about. And I'm not confident about much, but I'm pretty confident that when it comes to suicidal ideation and depression, ketamine works right away, and it lasts for about a week to 2 weeks. We only have 6 studies of social anxiety and generalized anxiety, and these are done mostly by the same group. Some of them are retrospective, some of them are small, but we see the same thing. So, you'll notice these are small. That's why I put the numbers there. One study is 12 patients, another one's also 12 patients, and these are done by the same group. But what they show is 50% reductions in most patients, 10 out of 12, 8 out of 12 in anxiety, and social anxiety and generalized anxiety disorder. And also, the doses tell us that the higher the dose, the better. So I think we're starting to see that around 1 milligram per kilogram seems to be the way to go. OCD, similar. We also just have a couple studies there. But we did see similar sized reductions. So up to a week and starting right at 4 hours, substantial reductions in OCD symptoms. And I think that's really interesting because OCD is pretty distinct in some ways from depression. Most people who suffer with OCD, or a lot of them, are also going to have depression, but these aren't the co-occurring depressive symptoms. This is actually stopping the obsessing and the compulsive responses to that obsession. And even in the single dose of ketamine, significant transient benefits in clinician ratings right after. So we need more research on these anxiety disorders because they're also very prevalent. But for those of us who are treating folks with them, I think that there's enough to see that perhaps there's something there. PTSD, again, only a few studies, just 3. And these are a little different. So I think this is really interesting. And I think PTSD is going to be a big target for ketamine treatments because it is so dire and so refractory to many treatments. And the treatments that do work are incredibly arduous and time-consuming. So for a lot of folks who are really suffering, it's hard to engage them. So something that can offer quick relief is really valuable. And in these cases, we saw higher doses. So 6 infusions over 12 days. With military veterans. So if you think about that, that's quite a heavy dose, but significant decreases in PTSD that seem to last longer. So in this one study at 14 days, 80% were still in remission, and even at the end of about 2 months, still 40% remission. So it could be, and it's early to say, but it could be that this higher dosage regimen, more frequent dosing, leads to longer term effects. And again, but also in the single intravenous administration in an RCT, we also saw good reductions in symptoms, but not long-lasting. So what this suggests is that we do need the repeated dosing to get those long-lasting effects. And I'm going to finish off by talking a little bit about substance use disorder. You saw Krupinski? Yeah, I got it. Okay. This is his study, so we talked a little bit about that, so I'll go back to that. But these are weird studies, a little bit hard to unpack them, but I think they're worth discussing. Is comparing ketamine to aversion therapy, and 70% abstinent for ketamine versus 24% for aversion therapy. And at that time, aversion therapy was thought to be something that was pretty good. And what's remarkable, and he was very much integrating this with psychotherapy, so this is one of the things that gives me hope that the psychotherapy integration is going to make a difference. But what we saw in that was 66% abstinent even at 12 months, which is huge for alcohol use disorder. And there's also been a little bit of more recent studies, and this is just the single infusion with a motivational enhancement therapy, which is something that we're actually working on combining in Vancouver as well. And we see some pretty good results there. Lower likelihood of alcohol use and heavy drinking, even at 3 weeks compared to benzodiazepine. And at 60%, 75% abstinence at 6 months. So pretty good for a single infusion with motivational enhancement therapy. And I think motivational enhancement could be a good adjunct to ketamine, because if you think about it, you have that week, right? You have that week of feeling good, and that's time when you can plan, you can enhance your motivation, you can get ready to make some of those changes. So a week can be a big deal if you make the most of it and are working with a good therapist. Cocaine use, this is also by a single group out of Columbia, but Columbia University. So, sometimes it just happens, right? I didn't even plan that one. So the first ones, there's some experimental studies there where they look at cravings, and they found that after administering ketamine, people were less likely to crave cocaine, less likely to choose cocaine instead of money, which is an interesting paradigm. And this group, based on those, built it up. This is really a model of good science, the way this group works. They start with the experimental stuff and then moved into the RCT. And if you look at those results at 14 days, 48% abstinent in ketamine versus 11% in an active control, and much lower cravings. So is that because of reduction in depression that underlies the addiction? Is it a change in mindset? Is it a vision of new opportunity? I think those are interesting questions to follow up with. And I just want to finish up with opioid use disorder. Only 2 RCTs, again, coming from one group. So this is in its infancy, especially when you compare it to what we know about depression. For a higher dose in 70 heroin-dependent individuals, larger effect at the higher dose. So dose does matter. It's not just about getting there. It seems to be that. And I'm not sure why would dose matter for a single administration. I think it's really interesting. Is it because you increase the likelihood of having those mystical type experiences? And there's some studies showing that mystical experience has been an important part of it. So is that what the higher dose is? I doubt that the higher dose is causing those kind of physiological or chemical changes. So I think it is about the experience. And if there's one thing I really want to leave you with, it's that idea. And again, we see much higher abstinence in ketamine compared to several sessions compared to the single session. So I think we're really, a lot of that early research is a single session intravenous. So it's like really not a great test of the potential of this medicine. It could be that it could have a role throughout the whole process of detoxing and recovery from opioid addiction, which is an area of particular focus for our group of researchers. And it could be that an infusion of ketamine during detox with maybe a sequence of a few sessions as you're coming out and re-emerging could be a really good model. So this is what we know up till now. There's a few new studies coming out, but I think if you memorized all that, then you know what there is to know from the formal literature on ketamine and mental health. And if you have any questions, please shoot me an email. I'm always happy to talk about this stuff. And I just want to thank the rest of my lab, and thanks to the EntheoTech team for having me here. And thank you for your attention.